Hello everybody. So today we will be dealing with the anti-leprotic drugs, and we'll deal this chapter under the following headings. We'll see the classification, then we'll see in detail about dapsone and clofazimine, and we'll see the treatment modality that is followed, specifically the multi-drug regimen, and finally we'll go with the alternate regimen, and at last the lepra reaction, which is a reaction in leprosy, and all these are the important questions that have come in the exam. So this will be a sort of exam-oriented module itself. So let's begin with the classification. I have already drawn the classification chart over here, which is better. So antileprotic drugs are classified into four major groups. So one is sulfones, the other one is phenazine derivatives, third one is the anti-tubercular drugs, and fourthly the other antibiotics. So only example for sulfone which is used as an antileprotic drug is dapsone. All others have become obsolete. Then phenazine derivatives is clofazimine. Anti-tubercular drugs, it is rifampin or rifampicin, both are one and the same, and ethionamide, which is used. And other antibiotics includes ofloxacin, moxifloxacin, minocycline, and clarithromycin. So remember that these drugs, dapsone, clofazimine, and rifampin, so these are the first line treatment for leprosy. All the other drugs fall in the second line treatment. So we'll start with dapsone. Dapsone is also called as diamino diphenyl sulfone, DDS. So you can find the structure that I have drawn here. It's not important, but just for your understanding, diamino diphenyl sulfone. What is the mechanism of action of this dapsone? So this is chemically related to sulfonamides, and hence they are having the same mechanism of action as that of sulfamides. What is that? It inhibits PABA incorporation into folic acid by folate synthase. So basically these leprabacilli, they will utilize the para-aminobenzoic acid, that is PABA, for the synthesis of folic acid, which in turn is necessary for its growth and multiplication. But dapsone, since it is structurally similar to PABA, it will competitively inhibit the folate synthesis. You can find the flowchart that I have drawn. That is a normal cycle which happens in the leprosy, and that will be inhibited by dapsone. It competitively inhibits folate synthesis. By doing so, what it does, it's going to have a leprostatic effect. It's not going to kill the bacteria, but however, it is going to make the bacteria static. So it's having a leprostatic effect. Fine. So I have written something called as persisters over the right end. What does that mean? So before dealing with persisters, we have to see something called as resistance. So initially when dapsone was given as a monotherapy, resistance was developed in patients. So patients developed resistance, and actually there were two types of resistance, primary and secondary resistance. Primary resistance in the sense you have not treated the person at all. Even before you have started the treatment, the person was found to have dapsone resistant bacilli. How can he have dapsone resistant bacilli even before giving dapsone? There is only one possible way. The bacteria with which he got infected, that itself was dapsone resistant. In the sense he has got this bacteria from a patient who had developed resistance. Okay, that is the only way possible. So that is primary resistance. Even before you have started the treatment, he has got that resistant bacteria in him. Secondary resistance in the sense he was having the normal bacteria which was not resistant, but after you started the treatment, it became resistant. So that is secondary resistance. Because of the monotherapy, it has developed resistance. That is secondary resistance. Now, these resistant bacteria can relapse. Okay, and when it comes to persisters, these are not resistant bacteria. These are the dapsone sensitive bacteria itself, but they undergo the tissue. But they will go into the tissue. They will enter into the tissue and they will hide there. They will enter into the dormant state, and that's why they cannot be killed. They're called as persisters, and after the treatment is withdrawn, these persisters can come up and they can again cause this relapse of the disease. So they are persisters. And so coming to the pharmacokinetics, it is given orally and it is completely absorbed from the gut. It is bound to plasma proteins and it is widely distributed in body. However, it is not penetrated into CSF. It is poorly penetrated into the CSF. Now concentrated in skin, especially the lepromatous skin and the muscle, liver, kidney, etc. It is partly secreted in bile and undergoes enterohepatic cycling. So it will be excreted in urine. Plasma dehuff is usually more than 24 hours and elimination takes from 1 to 2 weeks or even longer than that. What are the adverse effects of this dapsone? The major adverse effect is the hemolytic anemia, which is dose related, and this is more prevalent in those people who have G6PD deficiency. Other than this, you can find GI symptoms like nausea, vomiting, anorexia, allergic dermatitis, itching, peripheral neuropathy is seen, methemoglobinemia can be seen, there is something called a sulfone syndrome which can be seen. Sulfone syndrome is nothing but the exacerbation of lesions. That is, the reaction is develops after 4 to 6 weeks from starting the dapsone treatment. Now, this includes fever, malaise, jaundice, lymphadenopathy, anemia, dermatitis, pruritus, so on. And how do we treat it? We simply withdraw the dapsone treatment and give corticosteroids in place. Now, other uses of dapsone, of course, in combination with pyrimethamine, it is used for chloroquine resistant Plasmodium falciparum, that is a malaria, and even in toxoplasmosis we give this. Some fungal infections like zero AC we give this. So that's about dapsone. Now coming to clofazimine. So clofazimine is a dye with leprostatic and anti-inflammatory property. So it is also static. It's also not going to kill. It's also leprostatic and it's having an anti-inflammatory property. So this anti-inflammatory property will be useful in the lepra reaction. So clofazimine is one drug which is used in lepra reaction, and here you get the rationale of it because it is an anti-inflammatory drug. That's why we are using it in lepra reaction. Fine. So mechanism of action, the first point is very important, that it interferes with template function of DNA in the mycobacterium. Template function will be interfered. Then there will be also the alterations of membrane structure and transport function. There can be disruption of the membrane electron transport chain. However, the first point is very important, don't forget that. Coming to pharmacokinetic, it is active orally, so 40 to 70% will be absorbed, and it accumulates in the macrophages and gets deposited in many tissues as needle-shaped crystals. And entry in CSF is of course poor, but T-half is 70 days. Coming to the adverse effects, you can guess it, I guess, because I already said that it deposits in various tissues. So there will be reddish black discoloration of skin, even secretions will be discolored, like tears, sweat, urine, they can also be discolored, hair will also be discolored, there will be pigmentation of conjunctiva and phototoxicity is also seen. But however, the most common symptoms are the GI symptoms, that is nausea, vomiting, diarrhea, abdominal pain. These are most commonly encountered. So now we have seen about two different drugs. We are at the position of going to the treatment modality. So we all know that leprosy is classified based on the Ridley and Joplin classification into 5 groups. They are tubercular leprosy, borderline tubercular leprosy, borderline leprosy, borderline lepromatous leprosy, and lepromatous leprosy. Lepromatous leprosy will be having the highest number of bacilli. To the other extreme, the tubercular leprosy will be having the least number of bacilli. Right? So lepromatous leprosy, here the cell-mediated immunity will be absent, and that's why the progression of the disease will be more. The lesions will grow more rapidly. Whereas on the tubercular leprosy, cell-mediated immunity will be normal. That's why their progression is quite less, at a slower rate. However, this classification is not useful for us for treating the patients. So for the treatment of the patients, we use multibacillary and paucibacillary classification. So paucibacillary and multibacillary are actually defined this way for our treatment. So paucibacillary in the sense, if there are 1 to 5 skin lesions, it is paucibacillary. If there are more than 6, or if there are 6 skin lesions, immediately you classify it into multibacillary. Secondly, based on the nerve involvement, if by chance more than one nerve is involved, irrespective of the number of lesions involved, you classify it into multibacillary. But if there is only one nerve involved, or if there are no nerves involved, and the skin lesion is less than 5, then you will classify it as paucibacillary. Of course, the skin smear is negative at all sides in paucibacillary, but in multibacillary, it will be positive at any one side. So what is a multi-drug regimen that is followed? See, I already said you that monotherapy was followed, but then resistance developed. So now what we are using is a multi-drug treatment. And I already mentioned you that there are 3 first-line drugs, which are the dapsone, clofazimine, and rifampin. The same 3 drugs I have mentioned here. So these are the multi-drug regimen treatment which is given. So what we give is basically the rifampin or rifampicin, whatever it is. We are going to give it 600 mg once a month, and it is under the supervision. So it cannot be taken on your own. So I have marked all those ones which are supposed to be given with supervision in green, and self-administered ones in pink. Yeah. So rifampin 600 mg once a month is given under supervision. Dapsone 100 mg daily is self-administered. Clofazimine 300 mg once a month is supervised, and 50 mg daily is self-administered. So this is for multibacillary. For paucibacillary, once a month you will give 600 mg rifampin under supervision, and daily you will take 100 mg dapsone on your own, self-administered. Right? Clofazimine is not given for paucibacillary. And what duration should we follow this? The duration for which this is followed is 12 months in multibacillary and 6 months in paucibacillary. Clear? So this table is quite important. Other than this, there are some alternate regimens which are followed. What are those alternate regimens? The first one is intermittent ROM. ROM stands for rifampin, ofloxacin, minocycline. So rifampin 600 mg, ofloxacin 400 mg, minocycline 100 mg. These are given for around 3 to 6 months in paucibacillary cases and 12 to 24 months in multibacillary cases. This is called as intermittent ROM. And for single lesion paucibacillary lesion, we were giving single dose ROM. Same rifampicin, ofloxacin, minocycline. We were giving it earlier for single lesion PBL, but it is discontinued right now. And thirdly, we will follow some very new modality, that is for the 6 months we will give one treatment, and for the next 18 months we will give another treatment. First 6 months we will give clofazimine 50 mg. Along with that, any two of the new drugs. Any two. It might be ofloxacin and minocycline. It can be minocycline and clarithromycin. It can be ofloxacin and clarithromycin. Doesn't matter. Any of the new drugs, any two of the new drugs should be given along with clofazimine for the first 6 months. After that, for the next 18 months, we are supposed to give clofazimine along with any one of the two drugs, either ofloxacin or minocycline. Followed? So this regimen is followed. And all these drugs are daily drug, once daily drug. That's why I have written OD. So once daily. So these are some of the alternate regimens that are followed in leprosy. So now let us see the reactions in leprosy. So we know that these are the immune mediated reactions that occur during the course of the disease. The exact cause of such reactions is not known. However, it is usually precipitated by infection, trauma, mental stress and so on. Actually, there are two types of lepra reactions. We already have studied this in microbiology. The type 1 lepra reaction and type 2 lepra reaction. The type 1 lepra reaction is delayed hypersensitivity reaction, that is type 4 hypersensitivity, and lepra reactions, that is type 2, is nothing but the immune complex mediated reaction, that is type 3 hypersensitivity. Okay. And in our KDT, what they have mentioned is they have mentioned lepra reaction and reversal reaction. So by lepra reaction, what KDT means is this type 2 lepra reaction, and by reversal reaction, what they mean is type 1 lepra reaction. Okay, fine. So this is the differences. We'll go through this later. Now lepra reaction, that is type 2 lepra reaction. It usually occurs in lepromatous leprosy, and it usually coincides with institution of chemotherapy, and it is due to the release of antigens from killed bacilli. That is why it is antigen antibody complex mediated reaction, and it can be mild, severe or even life threatening, that is erythema nodosum leprosa. It will be of abrupt onset. Lesions will enlarge, become red, swollen, painful, and new lesions might also appear. Malaise, fever and other symptoms will be accompanied. And what we do here is we temporarily discontinue the dapsone only in severe cases, and we of course will go with clofazimine. It is effective in controlling this. I already mentioned it's having an anti-inflammatory property, so here we are going to use it. And for severe reactions, we are going to use prednisolone, and we continue it till it subsides. But however, we are going to taper it over the next 2 to 3 months. We don't abruptly stop this. Along with this, we can use analgesics, antipyretics, antibiotics, and in fact, anti-malarial drug, that is chloroquine, is also used for this lepra reaction. Thalidomide is also used. However, it is having teratogenic properties, so it is not usually preferred. Only in cases of alternative to prednisolone it is used. Next, coming to the reversal reaction, it is seen in tuberculoid leprosy and any other cases, and it is a manifestation of delayed hypersensitivity. And here you can find cutaneous ulceration, multiple nerve involvement with swollen, painful and tender nerves, and it is treated with the clofazimine and corticosteroids in the same way as erythema nodosum leprosum. However, here we do not use thalidomide, and this is the differences. So thank you.